So today, I'll be presenting a clinical pathological conference CPC by our department. The title is "Oh no, I can see well after taking a hot shower." So from the topic here, we know that this is actually a tough phenomenon, which is a typical symptoms of multiple sclerosis. So Dr. Low will be presenting on the case, followed by Associate Professor Dr. Shahizon. She will be commenting on the imaging of the patient. And then subsequently, Associate Professor Dr. Rabani will talk about the diagnosis and also management of multiple sclerosis, and maybe a little bit of differences between multiple sclerosis and NMOSD. And then after that, will be concluded by me. I'll be talking about how do you assess optic neuritis from a non-ophthalmology perspective. So without further ado, I'd like to invite our first speaker today, Dr. Zoe. She's a medical officer of Department of Ophthalmology. She'll be presenting the case. Welcome.
Thank you, Dr. Teck. Can the lights that is shown to my face nak tutup lampu? Boleh. Thank you. So very good morning to all who are present in the auditorium today. My name is Zoe. I'm a medical officer from the ophthalmology department who will be presenting on the case today. So without further ado, let's begin to unfold the story of, oh no, I can't see well after taking a hot shower. I've got an interesting case of a 33-year-old female by the name of Mrs. NKMS. She presented to the eye casualty with a left eye blurry central vision for the past 5 days. This central blurry vision isn't her first attack. This was a third episode of attack. First was in March 2017, followed by 7 months after, which she had her second episode in October 2017. The affected site was her left eye. The onset was acute, and it progressively worsened in the past 5 days before becoming static. Her left central blurry vision character was persistent, but the severity was not affecting her daily chores. The exacerbating factors were hot showers, physical exertion, hot ambient temperature, while relieving factor was cool ambient temperature, which provided her only slight relief. Associated symptoms were pain on eye movement, a dull ache behind the eye. She graded her pain score as 2 out of 10. It was minimal and tolerable pain. The pain worsened after heat exposure, and there was also decrease in perception of color and contrast, especially in red color, which appears subtly washed out. Other relevant negative ocular history includes no restriction in extraocular motility, proptosis of diplopia, which could be suggestive of orbital tumors. There was no metamorphopsia or distorted vision, which excludes macular diseases. No photopsias, flashes, flickering lights, or zigzagging, which excludes ocular migraine. There was also no complaints of dark curtain or shadow moving across the field of vision, which excludes retina detachment. She did not complain of any eye redness, no photophobia, which excludes infectious or inflammatory uveitis causes. She denies any ocular trauma, which could be suggestive of traumatic optic neuropathy. Her relevant negative systemic history: she did not complain of any headache, nausea, or vomiting, no upper or lower limb numbness or weakness during this episode of admission, and no loss of weight or appetite, which excludes tumor or space-occupying lesion. She denies any rashes, joint pain, mouth ulcers, or alopecia, which excludes autoimmune disease. There was no preceding viral illness or URTI-like symptoms such as fever, cough, and runny nose, which excludes post-infectious etiologies. There was no persistent dry cough, no swollen lymph nodes, fatigue, pallor, bleeding tendencies, which excludes infiltrative causes of sarcoidosis, lymphoma, and leukemia. There was no recent travel, no jungle trekking, no swimming in the lakes of river or rivers, no pets at home, and no cat scratch exposure. No high-risk behaviors, and no history of contact with tuberculosis-infected patients, which excludes infective causes or neuroretinitis. Her past ocular history, she uses glasses for myopia. Both eyes had powers of about -1 diopters, and she had 2 previous admissions for left retrobulbar optic neuritis. Her first episode was in March 2017, where she presented with symptoms of seeing blurry image over her left upper temporal quadrant for a period of 4 days. She was treated with IV methylprednisolone 500 mg BD for a period of 3 days, and vision recovered to baseline. 7 months after that, in October 2017, she presented again with symptoms of central blurry vision of her left eye for a period of 4 days. She was once again treated with IV methylprednisolone 250 mg QID for a period of 3 days, and MRI orbit imaging was done, which showed non-enhancing high signal intensity at the intracanalicular portion of the left optic nerve, suggestive of subacute or chronic optic neuritis. Vision then recovered to baseline after treatment. Now let's go into her past medical history. She had childhood bronchial asthma and history of multiple admissions. Her first admission to us in UKM was March 2013, where she actually presented with symptoms of back pain. She was diagnosed with transverse myelitis. Imaging was done. MRI brain and spine showed long segment intramedullary lesion at C3 to C6 level, and also T11, most likely representing demyelinating disease. She was started with IV MP 500 mg once daily for a period of 5 days. 6 months after, there was a recurrence of symptoms of left lower limb numbness and weakness this time. She was diagnosed with a relapse of transverse myelitis. MRI brain and spine showed more conspicuous intramedullary lesions associated with cord expansion involving the C3 to T2 level and new periventricular lesions in the brain. She was admitted once again for IV methylprednisolone 500 mg once daily for a period of 5 days. After that 2 admissions in 2013, and she had that ophthalmology admissions in 2017 for retrobulbar optic neuritis. A neuroradiology conference was held in November 2017, where MRI brain and spine showed new juxtacortical and periventricular lesions seen, with multiple short segment spinal cord lesions. C2 to T4 was also seen. The diagnosis of relapsing remitting multiple sclerosis was then made. She had a 5th admission in December 2020, 3 years after her last relapse, where symptoms that she was presented with was bilateral upper and lower limb weakness associated with facial numbness. MRI brain and spine showed unchanged T2 periventricular lesions with less conspicuous cervical medullary and also cervical spinal cord lesions. There was no new brain or spinal cord lesions. She was given IV methylprednisolone 500 mg BD for a period of 3 days. She had no past surgical history. She also has a younger sister who is diagnosed with multiple sclerosis and is under Hospital Kuala Lumpur follow-up. Social history-wise, she's married, blessed with a daughter, lives in Cheras and works as a part-time online Arabic language tutor. She's a non-smoker and a teetotaler. Drug history, she's on subcutaneous interferon beta-1a, Rebif, 44 micrograms 3 times per week. She performs herself injections since November 2017. She's also on oral cinnarizine 25 mg TDS and also amitriptyline 12.5 mg once daily. And she stated that she is compliant to all the medications prescribed to her. She has no allergic history. Her vaccination history consists of 3 doses of COVID-19 vaccine and a booster dose a year ago prior to current illness onset. In summary, Mrs. NKMS, 33 years old lady with relapsing remitting multiple sclerosis, presented with recurrent left central scotoma triggered by hot showers which persisted for 5 days. Symptoms were also associated with pain on eye movement, a reduce in color and contrast sensitivity without any systemic involvement during this attack. This is our ocular examinations. Visual acuity over the right eye was 6.6 with a near vision of 6, while in the left eye, it's 6.9 pinhole with a pinhole 6.9 and near vision of 6. REPD was positive grade 2 over left eye. Her extraocular motility was full on both eyes, but there was pain and on adduction and abduction of the left eye. Other anterior segment findings were unremarkable, except the pupillary reflex, which I would like to emphasize here. On the right eye was 3 millimeters in dark, and it further constricted to 2 millimeters upon when being shone by light. It was a breeze reflex, while the left eye was 3 millimeters in the dark, and it further dilated to 4 millimeters when shown to light, with the initial stall followed by greater redilation, which indicated a positive grade 2 RPD. Otherwise, both eyes had normal intraocular pressure of 12. This is the fundus photo of the patient. Both eyes had normal fundus findings with optic disc of with pink optic disc bilaterally, with a cup disc ratio of 0.3 and normal macula, and also a flat peripheral retina. The optic nerve function test of this patient. Left eye had a red saturation of only 60% as per compared to the right eye, that was 100%. Light brightness was 80% over the left eye as compared to the right eye. However, the color vision, where we carried out a Farnsworth D15 test, was normal bilaterally. Her J-REMS perimetry did not show any abnormal findings. It was normal bilaterally. But let's take a look at the Humphrey visual field, which was carried out for her. Her right eye had normal findings, while the left eye had central sickle scotoma with a central point fixation involvement and also involvement of the blind spot. Her systemic examination. She's a petite lady with a normal BMI of 20.8, and she was, other vital signs were normal with unremarkable systemic findings. Her neurological examination, she was alert and oriented to person, place, and time. There was a deficit in the optic nerve, the cranial nerve number 2, and all other cranial nerves were intact. There were no other neurological deficits in this during this time of admission. These are her baseline investigations, baseline blood investigations that was taken prior to the commencement of the IV methylprednisolone. Her infectious findings for infective screening, all results came back normal. Our impression at the time was recurrent left retrobulbar optic neuritis secondary to underlying relapsing remitting multiple sclerosis. Acute management, we co-managed the case with neuromedical team. Treatment was by using a regimen according to the ONTT trial, the optic neuritis treatment trial. Pulse intravenous methylprednisolone 1 gram for 3 days, followed by oral prednisolone 1 mg per kg per day for 11 days in tapering doses. She was also covered with a gastroprotector or pantoprazole for the mg once daily. No imaging was done during this admission because diagnosis was made solely based on clinical judgment, and patient has then recovered to baseline. Vision has recovered to baseline, and she is planned for MRI brain and orbit as outpatient on the 5th of September 2023. This brings an end to my presentation, and I thank you for your time. Now I would like to invite Professor Dr. Shahizon Azura Mohamed Mukari from the Radiology Department to tell us the interesting findings of this case.
Thank you, Dr. Zoe. I think Dr. Zoe has already outlined the chronology of the imaging for this patient. What I'm going to do is basically to show you what the abnormalities are, and if you see it, you know how it looks like, and you have a vague idea of what multiple sclerotic plaque look like on imaging. Right, so the first cervical MRI was done way back in 2013 for this patient. And here you can see that there is a long segment intramedullary lesion that extends from around C3 to C6 level. I think you can see it, what the arrow is showing. It is a bit patchy, and it is best seen on the axial scan. That's the marker on where the axial scan was done. And the sequence that is showing is the T2, T1, and the post-contrast on the far left. And here you can see that the lesion, the abnormal signal intensity, is eccentric in location. And this is very typical for a plaque, MS plaque. And it shows a little bit of enhancement, but it's a bit subtle. The second MRI, brain and spine. I'm not showing you the brain yet, but the spine, it shows that the lesion is extending even further down. And you can see that there is also eccentrically located lesion. And this is, again, very typical for an MS lesion. What about the MRI brain and orbit, which was done in 2017? So I hope you can appreciate that there are multifocal lesions. Majority of them are ovoid in shape. And again, this is quite typical for an MS lesion. And location-wise, they are periventricularly located. Some typically will be at the callososeptal interface. And it shows a lesion which is perpendicular to the ventricle. This is typical of a Dawson finger. Right. So this is a magnified view. You can see that there are multiple lesions, and the lesion has a different signal and different characteristic. The lesion here on the right side, you can see that there is enhancement, indicating that this is something which is active and recent. And the other lesion here, it looks very hyperintense on T2, and it's hyperintense on T1. Then there's no enhancement, meaning that it's something which had happened a while back. So this is a Dawson finger. You can see it better on the sagittal plane, perpendicular to the ventricle. So this is typical of Dawson finger that you see in MS. And MRI, brain and orbit, coronal view would be best to look for the optic nerve. Here is the pre-chiasmatic optic nerve just before it joins to become the optic chiasm. And I hope you can appreciate here on FLAIR that there's different signal intensity of the optic nerve. This is the right and this is the left. You can see that there is an hyperintense signal on the left optic nerve. You barely see it on the T2 simply because the CSF fluid is competing with the signal of the hyperintense optic nerve, so you can't really see the distinction very well. Hence why FLAIR is a good sequence to look for this abnormality. And on contrast, you can see that there is enhancement. So this is changes that would be typical of optic neuritis. The axial scan, it's a little bit challenging, but you can also see the changes here. This is a T1 fat set post-contrast. The reason why we do fat set is because we want to suppress the fat signal, especially in the orbit, so we can see distinction between the optic nerve itself. If not, you won't be able to see the optic nerve very well, especially when there is enhancement. And I hope here you can appreciate that there is a little bit of enhancement of the left optic nerve. You can't really see very well here on T2. So in summary, this patient has got spinal lesion, long segment intramedullary lesion. It's eccentric in location, and there's a little bit of enhancement. And in the brain, you can see multiple lesions. Over time, you can see some new and old lesions. They are located perpendicular to the ventricle, which is typical of a Dawson finger. And there is also optic neuritis. So in this patient, we see the typical finding of an MS of a multifocal lesion, which is disseminated in space and time. And this is very typical of multiple sclerosis. Thank you.
Thank you, Professor Dr. Shahizon, for the interesting imaging that you just showed to the audience. Maybe we allow a few questions from the audience because Prof. Shahizon need to leave the CPC for exam purpose. Is there any question from the audience so far regarding the imaging? Oh yes.
Assalamualaikum, Prof. Shahizon. I'm Faizal from Oftal. I got one question because if you can see that NMOSD also, we can find also the spinal cord involvement is long segment, more than more than 3 segments, like in this case. So how you differentiate between MOSD and optic neuritis MS in the finding of the spinal cord involvement?
Right, okay.
Thank you.
Majority of time, NMOSD would present as transverse myelitis. And the on axial scan, the area of involvement usually would be central, and it involves more than 2/3 of the spinal cord. Unlike this lesion, you can see that the lesion is eccentrically located. That is typical for MS. For MS. And the other thing is that you would look at the brain as well. If you see that there is Dawson finger, that's quite highly specific for MS. You don't really see Dawson finger in NMOSD. So whenever we see a long intramedullary lesion in the spinal cord, and you're suspecting demyelinating lesion, transverse myelitis, you have to do the brain, because this is how you can at least filter out and differentiate between the two. Okay, I hope that answers the question.
Prof, just to clarify, so for NMOSD, can we say that there won't be any lesion in the brain?
No, you can see lesions in the brain, and NMOSD usually would be involving what I call a central part of the brain. So it will be along the ventricle. It's actually similar like this, but the distribution and the presence of Dawson finger points against NMOSD. But majority of time, sometimes we don't see lesions in the brain. If you don't see lesions in the brain, then most likely it is NMOSD. And again, you have to look at how it looks like on axial. Actually, if you see this lesion on the, even though it's long segment, it is not homogeneous, the typical transverse myelitis that we see. It is actually patchy, tau. It's actually patchy. And on axial, it's confirmed that it is, you see it here and there. It's not continuous, longitudinal, that is typically seen in transverse myelitis of NMOSD.
Thank you, Prof.
Right.
Is there any other question from the audience? If there's none, I would like to thank Professor Dr. Shahizon for the interesting talk. And next, I would like to invite Professor Dr. Rabani to come out on stage to talk about multiple sclerosis from a neurologist's perspective.
Thank you, ophthalmology team, for inviting me to share my insight on multiple sclerosis, and hopefully at the end of this CPC that everyone in this hall would be able to recognize some imaging features, recognize clinical presentations. I wouldn't expect that you all would treat, but refer to us if there's any suspicious case, all right? Okay. So I'm going to speak on multiple sclerosis diagnosis and management, but I think within a very limited time, I might not go through very detailed. So just like to show you that multiple sclerosis is more prevalent in young Caucasian adults. All right, so this is one of the leading cause of neurological disability, and MS affect up to 2.5 million people worldwide. So if you look at the global prevalence of multiple sclerosis in this global map, the Caucasians are at greater risk. All right, so their prevalence about 60 to 140 per 100,000 in Northern Europe, USA, Canada, Australia, and New Zealand. And when you go to Central South America, the prevalence reduced to about 220 per 100,000 population. And in Asia, the reported prevalence are about 5 in 100,000 population. And women are up to 3 times as likely to develop MS. These are common in most of autoimmune disorders. And MS generally affect people in their prime of their life, right? So, and typically begins between age 20 to 40 years old, similar to our case presentation today. So what about in Malaysia? Prevalence of multiple sclerosis in Malaysia is ranging from 2.73 per 100,000. Only 60% are detected and diagnosed. So there are many more patients outside are not detected and perhaps not diagnosed or misdiagnosed with, for other neurological condition. and 60% are multiple sclerosis, and we have another portion of patients with demyelinating disorders belongs to neuromyelitis optica spectrum disorders. Majority of patients are 80% relapsing remitting multiple sclerosis. So what is multiple sclerosis? Right, so I'm not going to go through a detailed pathophysiology because I'm sure that all of you can go back and look at the busy pathophysiology diagram. So it's an autoimmune demyelinating disease of the central nervous system, which can be triggered by environmental factors and act on genetically susceptible hosts. Right. So there are 3 clinical stages. The preclinical stage detectable only by MRI, and a relapsing remitting stage characterized by episodes of neurologic dysfunction followed by resolution. A progressive stage which usually evolve from relapsing stage. On the right-hand side shows common symptoms of multiple sclerosis. As what we can see in patient that we presented today, the beginning of the earlier presentation was transverse myelitis, and subsequently she had a recurrent episode of optic neuritis. But bear in mind, there are other symptoms. The patient can present to you with just generalized fatigue. They can present to you with brainstem symptoms, vertigo. They can also present to you with just urinary incontinence or urinary retention, cognitive dysfunction, tremors, muscle-related symptoms. They can also present with sexual dysfunction. So, in view of variety, different non-specific or atypical symptoms, this can make diagnosis of MS rather challenging. So usually the first clinical presentation defined as clinical isolated syndrome. So this is the first clinical neurological episode when a patient has symptoms and signs suggestive of MS. So 2/3 of patients presented with CIS, clinical isolated syndrome, will have further clinical episodes or new relapsing remitting multiple sclerosis, or they evolve and finally fulfill clinical definite multiple sclerosis. So if you look at the types of multiple sclerosis, you can divide it into clinically isolated syndromes, relapsing remitting multiple sclerosis, secondary progressive MS, and primary progressive MS. But as I mentioned earlier, that we in Malaysia, or generally majority of patients belong to relapsing remitting multiple sclerosis. This is the best time to catch the patient because there are multiple treatments available, and if you treat with the recent medication that are available, they might have a longer remission rate, reduce disability, and also improve quality of life. So if you look at this diagram, if I can show you, clinically isolated syndrome is the first episodes of patient-reported symptoms. But if you look at this, there's another category where they call it preclinical radiological isolated syndromes. So at this point, when the patient does not overshoot the clinical threshold, they do not come and present to you with any neurological symptoms. But generally, you don't do MRI or imaging in patient who does not have symptoms. But the patient usually start to have radiological isolated lesion before they overshoot their clinical thresholds. So when the disease progresses, they may present to you with clinical isolated syndromes. So at this point, you can see that they might have disability from the first neurological presentation. Majority of the patient improve, and they, as I mentioned earlier, perhaps 30% of them does not have another neurological relapse. But majority will have multiple relapses, and this is when you will see the relapsing and remitting patterns. When they comes into this stage, you can see that they will develop multiple lesion in the brain. Hence, treatment is indicated so that we can allow the patient to be in remission, reduce clinical attack, and most importantly, reduce disabling attack. Because most of the treatment that we have to treat multiple sclerosis is not 100% guarantee that the patient does not going to develop any attack. Yeah. So, and MS is not only about neurological deficit. when we review patient with multiple sclerosis over the years, we will see that the brain volume is also reduced. All right. So this over the years, it will also affect their cognitive impairment, cognitive ability, and this, if they have MS at age of 20, you just imagine at age of 40, they might have low MMSE score. I'm not going to go through in detail about secondary progressive, but if we don't treat relapsing remitting stage well, patient will progress to secondary progressive MS, and at this stage, usually there will be no reversibility, and the neurological deficit will be progressive and making the patient to become disabled. Primary progressive MS is actually has a lower percentage, and the treatments are rather challenging for this group. So I'm not going to discuss that group in detail. So what is the key principle for diagnosis of MS? Okay, so I think we listened to Dr. Zoe earlier, the clinical presentation. All right, so they can present with multiple neurological conditions, typically optic neuritis and transverse myelitis. But not to forget, they can have trigeminal neuropathy. They can present to you with brainstem symptoms. All right, so what you need to do is actually ensure that you uncover the evidence that demonstrate lesion in the central nervous system. So the imaging is required for us to demonstrate lesion in the brainstem, in the brain as well as in the spinal cord, and showing dissemination in space. Like Prof. Shahizon mentioned just now, there are lesion in the periventricular, there's also lesion in the spinal cord. So this suggests there is a dissemination in space. And also dissemination in time suggests that the damage has occurred more than once. So if you look at the brain MRI, we can differentiate whether there is a dissemination in time. If we have a radiological imaging shows enhancing lesion in one area with non-enhancing lesion in the other part of the brain. So that suggests that the enhancing lesion is the acute lesion and the non-enhancing lesion is the old lesion. So by looking at the MRI, we can actually show evidence of dissemination in time. All right. So on the left-hand side is the summary of the 2017 recent latest McDonald criteria for diagnosis of multiple sclerosis. It's actually quite confusing to read now. I think you all can go back and look at the McDonald criteria, but again, look at the key principle of diagnosing of multiple sclerosis. All right. So again, you need the clinical presentation. If you have two or more clinical attacks with two evidence neurologically, you can actually make a diagnosis. But again, MRI and a CSF analysis would be important to help into making a complete diagnosis of clinical definite multiple sclerosis. So I just like to highlight what is the new thing in McDonald criteria 2017. If the patient presented with clinical isolated syndrome, only one neurological symptoms, and the CSF oligocorner band positive. So these positive findings of oligocorner band in the spinal fluid can substitute for demonstration of dissemination of lesion in time. So again, this is allow us to make early diagnosis of multiple sclerosis because we don't want to wait for the patient to develop another attack. Because the second attack can be disabling, right? Disabling attack meaning that, they can have severe transverse myelitis where they end up with paraplegia. So you don't want to wait until they develop a disabling attack. So the other key changes in this new criteria is types of lesion. So both the asymptomatic and also now symptomatic MRI lesion can be considered to determine dissemination in space or time. So I think before this McDonald criteria 2017, we have to wait for the patient to have second clinical attack. All right. So with this new criteria, you have one patient with clinical attack and you have the MRI that can show you dissemination in space and dissemination in time. You can already make a diagnosis of clinical definite and clinical definite multiple sclerosis, and we can actually initiate disease modifying therapy as early as possible. There's another key changes which the site of lesions. the cortical lesions now have been added to the juxtacortical lesion for the use in determining MRI criteria for dissemination of lesion and in the space. Okay. So I think we've gone through the clinical history, investigation, primarily MRI. Of course, we can also do CSF examination looking for ocular corner band. And we can also do visual evoked potential to assess the extent of the damage of the central nervous system. So how do we treat MS? Once we make a diagnosis, so we use McDonald 2017 diagnostic criteria. Once we make a diagnosis of clinical definite MS, how do we treat multiple sclerosis? Okay, so if you encounter any patient with optic neuritis or transverse myelitis, first episode, once you make a diagnosis, you suspect this is demyelinating disorders, you should treat for the acute attack, right? So acute attack, we usually use IV methylprednisolone, or in cases where the attack is very disabling, there's no improvement after methylprednisolone, we can offer IVIG or plasma exchange. Again, that is just to cover the acute attack, all right? So that's why we need to make a diagnosis of clinical definite MS for us to start disease-modifying therapy. So maintenance therapy will be a disease-modifying therapy because we need to start this medication to reduce new nerve damage and decrease or reduce the clinical attack. I will go through some of the disease-modifying available up to date, all right? And other treatment that we can actually start for this patient, for the MS patient, is symptomatic treatment or supportive management. You should also check, you can also give them vitamin D supplementation if they have low vitamin D, baclofen or botulinum toxin for spasticity in patients with transverse myelitis. Some of the patients develop lean spasticity. Neuropathic pain for numbness, for pain, neuropathic pain treatment. We can advise better diet, healthier diet, all right? Smoking, we have to advise them to stop smoking because smoking increases progression and disability. And always advise on physical exercise because it's beneficial to improve their mood, their fatigue, endurance, as well as cognition. So these are various drugs, disease-modifying therapies that are actually available. So if you look at the beginning, I think in early 1990s until early 2000, we are using more of immunomodulation, which is a maintenance therapy, and the clinical efficacy usually during the active treatment. So once you stop the medication, the patient will have no longer benefit and they will develop a clinical relapse. All right. So among medication under the immunomodulation are beta interferon and glatiramer acetate, but we don't have glatiramer acetate in Malaysia. Later on in year 2000, we have chronic immunosuppression medication, which is fingolimod, dimethylfumarate, teriflunomide, and these are oral formulation. So you can see the beginning, we have only injectable form. Beginning year 2000, we are having more a new medication, which now oral medication, which improve patients' compliance and reduce injection side effects. Yeah? And there's also high efficacy treatment with infusion medication where patient can come once a month for the infusion treatment. However, these treatments are only effective while patient on active treatment. So is there anything better? Is there any better treatment for this patient? All right. So I think beginning 2010 and until now, there are new medication or disease modifying therapy that are actually available, which is short course therapy, and we call it immune reconstitution therapy. And this clinical efficacy of this medication can extend beyond the period of active treatment. Right, so there are non-selective immune reconstitution therapy, including hematopoietic stem cell transplant, alemtuzumab. These are all monoclonal antibody. And there's also another selective IRT, which is cladribine. This is only in tablet formulation that the treatment, the patient will only need to undergo 2 years treatment, and after that, they don't need to be on any medication. All right, and then they can, a lot of our patients are in reproductive age group, so they can conceive. They just have to come for regular blood tests, and they do not need to take any more medication. And some of the patients, based on clinical data, they can be in remission, no attack up to, I think now up to 7, 8 years. All right, so these are very promising treatment. We do have this medication available, but I think at this time is based on insurance policy, and we do not have it available yet in our HUKM. Okay, what is the importance of making early diagnosis of MS? So I think first, we go back to the clinical presentation. You recognize the clinical presentation that might suggest demyelinating disorders. And we perform relevant investigation, MRI, and make an early diagnosis. All right? If you remember the first graph I showed, at the time of first clinical presentation, there's already multiple damage or lesion in the brain. All right. So the CNS damage is present from the very start of MS and progress even in the absence of clinical signs. So a lot of patients of MS who are on on therapy, we actually try to do yearly MRI because we wanted to see whether or not they have active radiological lesion. So if they still have active radiological lesion, then we probably need to think whether we have to escalate or give them higher efficacy treatment. All right, so I think based on Dr. Teck's request to actually show you what is the difference between multiple sclerosis and NMOSD. So multiple sclerosis, I think I've mentioned that earlier. Neuromyelitis optica spectrum disorder is also a demyelinating disorders, but they have the antibody that are responsible are different. All right. So if you look at the clinical features, the optic neuritis attack are usually more common in NMOSD compared to multiple sclerosis. And their optic neuritis are usually long segment and it can go right to the optic chiasm. So they are usually very severe. A lot of times they do not respond to the steroid therapy. So they are steroid responders. We have to know if they are non-steroid responders, then usually we have to do plasma exchange as soon as possible. So I think for ophthalmology, if you see the patient do not respond to your steroid within 1 or 2 days, you have to alert us because they might belong to this group. Yeah, because based on latest data, you know, some of centers actually, if they saw a very long segment optic neuritis, they will start steroid together with plasma exchange. So we don't wait for very long because you know, the vision might not recover after that. Yeah, visual loss severity usually less with more. I mean, not so severe in MS like what we see in this patient. She responded very well, and then the vision back to normal, despite having maybe 2-3 recurrent optic neuritis. However, in NMOSD, usually you will see very less improvement. White matter lesion on the brain MRI, I think as what Prof. Shahizon mentioned earlier, I have another slide to show the areas of involvement in NMOSD. And the spinal cord lesion, I think one pointed out, usually a big lesion with cord expansion, more than 3 segments, central lesion. And necrotic lesion, usually the enhancement will be along the whole more than 3 segments of vertebral bodies. So usually they are continuous. They are not skip lesion like I think the lesion that Prof. Shahizon showed earlier in our patient. And in multiple sclerosis, they are usually short segment, maybe just 1 vertebral body or 2 segment vertebral body. All right. Clinical involvement beyond spinal cord and optic nerve. If you remember, I mentioned earlier in multiple sclerosis, it also affects the cortical areas. It can also affect the cognition as well as mood, fatigue. It's more common in multiple sclerosis as compared to NMOSD. What about CSF analysis? Oligocornobrand is frequently positive, and when we look at the protein values are slightly lower in multiple sclerosis as compared to NMOSD. In NMOSD, we know that the antibody that are responsible is aquaporin 4 positive, aquaporin 4 antibody, and this positive antibody can range from 50 to 70% depending on the cohort of the patients. And the proteins tend to be higher. The total protein or the pleocytosis tend to be higher, and they tend to show more lymphocytes in their CSF. Functioning impairment during attack, they tend to be mild to moderate in multiple sclerosis, whereas NMOSD usually shows very severe functional impairment. So this is just to show you radiological typical MS lesion, gadolinium enhancing lesion, yeah, and this is Dawson's finger. I think we do not have a very we rarely see this. One thing maybe because of the resolution of the MRI, but the lesion centered by a small vein is very characteristic of multiple sclerosis. And a juxtacortical lesion, okay, this cortical lesion, all right. So this is your gray matter, right? And this is your cortical lesion. It's not easy to see, all right. I have to say that a lot of time the cortical lesion you need to see in a higher MRI resolution, maybe 5 or 7 Tesla machine. So we might miss this lesion. All right. So cortical lesion causing degeneration of cortical neurons, and this leads to cognitive impairments. All right. And this is an MRI lesion of the NMOSD. So if you look at, they are actually at slightly different areas. They can be rather confluent at the hypothalamus, and they can also be at this periimpendinemal brain lesion. They're slightly different. All right. So they are not the same as multiple sclerosis. So in conclusion, diagnosis and treatment of multiple sclerosis is challenging due to a variety of clinical symptoms. CNS damage is present from disease onset and progress even in the absence of clinical signs. So it's very important for us to recognize the clinical presentation or the important and relevant investigation to make an early diagnosis. And quality of life is seriously impaired as MS progresses. Early treatment provides opportunity to improve treatment outcome by preventing damage to the CNS. And again, we need to rule out other diseases that may present with similar presentation. I think in the interest of time, I managed to show you only NMOSD, but there are other conditions like more antibody disease, CNS vasculitis. Even we do have patients with brain tumor presented mimicking a patient with multiple sclerosis. I think with that, thank you very much.
Thank you, Associate Professor Dr. Rabani, for the very interesting talk. I feel a bit pressure because after listening to the two very informative talk by Prof. Rabani and Prof. Shahizon, me myself actually learned a lot from both of them. So my topic will be on how not to miss an optic neuritis. This is just a very basic slide. I think it will be beneficial for the medical student and also the emergency personnel and first liner to actually, pick up the optic neuritis and refer to us and also neurologists for further assessment and management. So first of all, just introduction on what is optic neuritis. Is any condition that causes inflammation of the optic nerve. So basically for medical student, if you see itis means it's inflammation. So optic neuritis means inflammation of the optic nerve. So it can be associated with demyelinating diseases. Either it can be, infections or inflammatory process. Just bear in mind, optic neuritis is just one of the causes of optic neuropathy. So we do have a mnemonic for causes of optic neuropathy, which is night ticks. So we have this neuritis, and then for eye, we have ischemic. It can be due to either a giant cell arthritis or vasculopathy. Vasculopathy means non-arteritic causes of anterior ischemic optic neuropathy. We have granulomatous, which mainly cover the infection, hereditary. If you have a trauma over the optic nerve, then it's called a traumatic optic neuropathy. Some medication can cause toxic optic neuropathy, such as methanol, ethambutol, methotrexate, and also amiodarone. And of course, radiation and also compression can cause optic neuropathy as well. So this is for the benefits of postgraduate students. A very common question to be asked during your viva: what are the typical symptoms of optic neuritis? So as I think Prof. Rabani have mentioned, the age usually is 20 to 50 years old, more female in male with the ratio of 3 to 1. Most of the time they are presented with unilateral involvement, and the symptoms will be acute blurring of vision, and then they will have maximum impairment within 1 to 2 weeks, and then the impairment will be stable for a little while. After that, they will have recovery starting within 2 weeks' time and have maximum recovery by 6 months. So these are the typical symptoms of blurring of vision. So if the blurring visions not fall into this chronological order, then you have to suspect other type of optic neuropathy. And since the optic nerve and also the extraocular muscle actually share the same sheath, so when there's an inflammation over the optic nerve, there will be also pain during the eye movement. And the other symptoms of optic neuritis is dyschromatopsia, which is reduced color vision. And when you assess the patients, there will be a presence of relative afferent pupillary defect. So just to recap what Prof. Rabani have talked on the multiple sclerosis, is a neurodegenerative disease of the central nervous system that can actually affect the nerve, the brain, and also the spinal cord. So based on the McDonald criteria, you need a dissemination in space and also disseminated in time. So in this patient initially presented with transverse myelitis, which we don't know whether this patient is multiple sclerosis or not, but subsequently, because in the subsequent attack there was actually optic neuritis attack, then here comes in the diagnosis of multiple sclerosis. And not to forget the recent 2017 revised criteria of McDonald criteria. You don't really need both of the dissemination of space and time. So for example, you have a first attack which involved 2 lesions, and then you either need a MRI to look for whether there's any old non-active non-enhancing lesion, or you can do a CSF fluid for oligoclonal band. If it is positive, then you can diagnose multiple sclerosis earlier on. So in multiple sclerosis, optic neuritis usually can be the presenting symptoms in 25% of cases. And for 75% of multiple sclerosis, there has at least 1 episode of optic neuritis in lifetime. So this shows how important optic neuritis in the diagnosis of multiple sclerosis. So just go back to the title of our CPC today. So it's orthophenomenon, means the worsening of the visual symptoms caused by the increase in temperature. Either when patient is exerting during exercise, having a hot shower, or when the weather is a bit hot. You need to bear in mind, only 1/3 of the optic neuritis were presented with optic disc swelling, just like in this photo. You can see you cannot, the optic nerve margin cannot be delineated. But 2/3 of the cases, the fundus will be normal. So the optic nerve will only become pale when they have a multiple attack and it's a chronic optic neuritis. This is because usually the demyelination happens at the retrobulbar portion of the optic nerve. We know optic nerve is actually extension from the optic disc from the fundus up to the optic chiasm. So demyelination can happen in between. So that's why it explains that some of the patient might not have any optic disc swelling during the optic neuritis presentation. So how do you not miss, how not to miss optic neuritis if solely based on the fundus photo or fundus examination, you can't see any optic disc swelling. So we need to ask a very detailed clinical history, supplement by our optic nerve function test, and also some workup for optic neuropathy. So today we are going to focus on what is optic nerve function test. So it consists of 5 tests. First is visual acuity test, RAPD assessment, red saturation test, light brightness test, and confrontation visual field. So first of all, we look at the visual acuity test. So all the patients that come to ophthalmology clinic, they cannot run away from visual acuity testing. This is like our bread and butter. So most of the time we're using a Snellen chart to assess the visual acuity. But if you are not in the eye clinic or you don't have the Snellen chart, you can actually have a handheld Snellen chart, or you can download apps with a reduced Snellen to actually grossly examine the visual acuity of the patient. So second, we have RAPD assessment, how to do a RAPD assessment. But before that, we need to understand what is relative afferent pupillary defect. It's a condition in which pupils respond differently to the light stimuli, shown due to either a unilateral or a bilateral but asymmetrical retina or optic nerve disease. So you need to know that the RAPD only present in the optic nerve pathology in front of the lateral geniculate body. So anything beyond the lateral geniculate body will not have RAPD. Means if you have an optic radiation lesion, then you won't have a RAPD. So also you need to know that if the condition is bilateral and also symmetrical for both eyes, you won't get RAPD also. So basically RAPD is to compare the afferent pupillary defect of one eye to another eye. So what we usually do is, this is called a swinging flashlight test or a Marcus gun test. So when you don't, not shining any light to the eye will be slightly dilated, about 3 to 4 millimeter. And then when you shine the light to the eye, you have this direct and indirect consensual light reflex. Both of the eye will be constricted. And then when you swing the eye to the other eye and you see there's actually different in terms of the constriction of the pupil, then you know there is positive RAPD. So what you need to do is just 2 torchlight. So next, I'm going to show how to perform a RAPD assessment. Hi, today I'm going to show you guys how to do a relative afferent pupillary defect. Hi, I'm Dr. Cheng. I'd like to check your pupillary direction. So first of all, to do a RAPD, we need to dim the room light. And then we have to stand at the patient's side and instruct patient to look at the distant target. Can you look at the distant target? This is to avoid the accommodation. After that, you should shine a light underneath to illuminate both eye pupils. So first of all, we need to check the direct and consensual light reflex. So we can shine the light over the right eye, and then we observe for both eye pupil constriction. This means that both the right eye having a good direct and consensual light reflex. After that, we shine the light over the contralateral eye to see whether both eyes is equally constricted or not. After we have examined the direct and consensual light reflex, we should swing the light for at least 2 seconds and swing to the other eye and swing back to the first eye. And we observe whether there is any relative afferent pupillary defect. So how to grade the relative afferent pupillary defect? So let's just assume that the left eye here is the pathological eye. So for grade 1, let's say you are shining the light to you just observe on the pupil. Let's say you just look at the right eye first. When you shine the light on the right eye, there will be pupil constriction. And then after that, you shine the light to the left eye, and you see the weak initial pupillary constriction followed by a greater redilatation. So this is grade 1. So for grade 2, same thing. You shine to the right eye, which is a normal eye. You'll get a good constriction, and then there will be an initial pupillary store. There won't be any pupil constriction, and then followed by a greater redilatation. So for grade 3, you can see on the right eye, pupil actually constrict well, but on the grade 3, there will be an immediate, without any initial pupillary store. The pupil will dilate immediately when you shine the light to the left eye. So for grade 4, if you shine the light to the normal eye, you will have a good constriction, but the pupil will be not reactive to the light and the pupil will be hemorrhagic, means that it's a fixed dilated pupil. This is in grade 4 RAPD. So I like to systematically divide the causes of RAPD into optic nerve pathology and retina pathology. So for optic nerve pathology, as for our CPC today, is on optic neuritis. Other causes of optic nerve pathology will be optic neuropathy, which I have summarized in the mnemonic of optic neuropathy, the night ticks, and also not to forget glaucoma is also one of the causes of optic neuropathy. So if you have glaucoma in both eyes with a symmetrical presentation, so you might not get an RAPD. So for retinal pathology, they can give rise to RAPD will be the retina detachment, central retina artery occlusion, or central retina vein occlusion, especially the ischemic type of CRVO. So we move on with the other 3 optic nerve function tests. Red saturation test. So these are the things that we do in the eye clinic. We show the tips of the dilating drops, which most of the time is in red color. It's actually a chilly bright red color of the tips of the bottle. And we ask patient to close one eye by one eye so that we can assess both of the eye at one time. So in a patient with the optic neuropathy, or in the optic neuritis specifically, so they will perceive that the redness will be slightly reduced. I mean, the color, the chili red kind of red color is actually more dull and also more darker compared to a normal eye. So you need to be clear with the instruction. Some patient might have some, refractive error or some media problem. So it's not about the clarity of the bottle that you see, but actually the color, whether it become more dull and darkish compared to the normal eye. So usually you require a comparison between the right eye and the left eye. So don't worry, if you don't have any dilating drop, you can use any of the red color, for example, pen torch or the pen. You just show the tips of the red color to the patient and ask whether the color they perceive from right eye and left eye is the same or not. So in this photo, actually the right photo shows that there is actually reduced in red saturation in this case. Next, we move on to light brightness test. So you also need a torchlight, a pen torch, to shine the light to the patients, and we ask patient to grade the light brightness. So most of the time we shine the light to the normal eye first. So we tell patient this is possible, like 100%, and then we shine the light to the contralateral eye and we ask in comparison whether they perceive as reduced light brightness or not. So in this case, the right eye is having a reduced brightness, which is also shown by Dr. Joy's examinations on our optic neuritis patient. So lastly is on confrontation visual field test. So confrontation visual field test, what are the prerequisites? First of all, you need to sit at the same eye level, and the target that you are giving to the patient must be equidistant. Means the target must be really at the center in between you and also the patient. The other important thing is when you are assessing patient's left eye, you need to close your left eye and use your right eye as a reference. So basically, for confrontation, this means that you are using your visual field to test on the patient visual field. So you must have a normal visual field in order to, to do a confrontation visual field. Otherwise, patient might be seeing a better visual field than you. So just a short video on how to perform a confrontation visual field. Hello everyone. Perform a visual field assessment. To start off with a confrontation visual field, we need to sit 1 meter apart from the patients. Make sure our eye level is the same. To do that, I have to adjust my seat height.
Sorry, the chair is not adjustable, so you can see I'm not at the same level, but the video has to be continued.
Visual field first. So I will ask patients to tell me how many fingers the patient can see.
2.
This is to make sure that patient can at least see a counting finger for me to proceed with my assessment. So I would like to instruct the patients to look at my face and tell me whether any part of the face is missing. So can you see my face? Is there any part of my face missing? Okay. This is to screen through the central visual field of the patient. I will then further divide the patient visual field into 4 quadrants, which is superior nasal, superior temporal, inferior nasal, and inferior temporal quadrant. While patients are closing her eyes, I will put my hands in front of the patients. I'll start off with the upper part of the visual field first. I will show my fingers and ask patient how many she can see. How many fingers?
1 and 2.
How many fingers?
2 and 0.
How many fingers?
0 and 1.
I will repeat to the inferior part of the visual field. How many fingers?
1 and 2.
How many fingers?
2 and 0.
How many fingers?
0 and 1.
So this patient have a normal visual field grossly.
This is just gross.
I'll ask patient to change her hand. Can you change your hand? I'll proceed the same screening test on the left eye. So now we are going to delineate the visual field by using a white and red pins. White pin is being used to assess the peripheral visual field, whereas red pin is for central visual field and blind spot. So again, I'm going to sit in front of the patients and ask patient to close the left eye. At the same time, I will close my right eye. I'll put the white pin at the center between me and patients, and then I will put the white pin away from our visual fields and slowly move in. Okay, let me know when you see the white pin in the visual field. Yeah? Please look in my eye and do not move.
So the instruction have to be clear. Patient have to look at your eye while you're moving the white target.
I can see it.
Okay, very good. I'll change my hand to access the nasal quadrant.
I can see it.
Okay, very good. How about this?
I can see it.
Okay, very good. It will be followed by using a red pin to access the blind spot and central visual field. So I will start with the temporal side and slowly move to the nasal side. Let me know when the red pin disappears. Can you see the red pin now?
Yes. 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 No, I can't see it now.
Okay.
I can see it now.
Okay, very good. So if we suspect that there is any enlarged blind spot, we need to further map the blind spot to assess the extension. I would like to repeat my visual field assessment for the left eye and ask patient to close the right eye. Can you change your hand?
So here's the end of the confrontation visual field video. So what are the typical visual field defects of the optic neuritis as mentioned by Dr. Zoe in the slide? So most of the time they have this central sickle. Why is it called central sickle? It's because the central visual field loss is together with the blind spot. Means it's, there will be a attachment between the visual field defect to the blind spot. Whereas in the central scotoma, it's a bit isolated from the blind spot. This is more for the macular pathology. So how patient perceive as a visual field defect when they have an optic neuritis attack? They will see the center part will be blur, something like a scotoma, but and also at the same time the color will be reduced, but actually the peripheral visual field will be acceptable compared to the central. So I'd like to just recap what are the optic nerve function tests that you can do if you are not an ophthalmology. Visual acuity test, RAPD assessment, red saturation test, light brightness, and also confrontation visual field. And this is just to conclude my slide. I'd like to acknowledge Dr. Nikki and Dr. Koo for the video which I took like 2 years ago. Thank you for your attention. Is there any question for Prof. Rabani?
or me myself, preferably to Prof. Rabani. From medical student, from master student? Anyone? I think must be Prof. Rabani give a very good lecture that there's no question from the audience. Okay, I think next we will proceed with the MCQ quiz, right? So I will pass over this to Encik Muhari. While waiting for the quiz to be on display, just to make sure, is there any question from the floor? So we have 6 questions prepared. It's a one best answer question.
Kita boleh mula sekarang
So I'd like to thank all the speakers of today, especially Dr. Zoe, who presented the case, and also Prof. Rabani and Prof. Shahizon for the very informative talk on the imaging of the multiple sclerosis and also diagnosis and management of the disease. I thank you, the audience, for staying with us on a Wednesday morning. I hope all of you learned something from the CPC today. With that, I concluded the CPC today, and thank you.